Good afternoon, ladies and gentlemen. A warm welcome from Eyezone Education team. Today we have all gathered here for an educational webinar on the topic Insights on Low Vision Practice. Before I introduce you the topic and our esteemed speaker, may I remind the audience of a few housekeeping rules. Please note this presentation is being recorded. To applaud, please use the clapping hands function, which is in the reactions button along the bottom toolbar. In order to see the speaker in full screen, please select speaker view instead of gallery view in the upper right corner of your Zoom screen. Switch your video off and mute the microphone to avoid intervention. This will conserve bandwidth and facilitate a smoother conference experience. Please type your questions into the chat box in your control panel and select the option to send them to the host. Note that questions will be filtered for the Q&A at the end of the webinar. We will do our best to accommodate all your questions. Thank you so much for your cooperation. Now, let's move on to the session you all are waiting for. Vision impairment is a major public health concern. In the Middle East, as in many other countries in the world, rehabilitation services are often not a priority for healthcare providers, and as a result, persons with visual impairment are not likely to achieve their full potential. Therefore, Eyezone's goal is to conduct a series of webinars and interviews on low vision topics to build awareness impairing disease. With us today to present the first webinar in that series is an expert who has done exemplary work in the field, Dr. Ithar Rishdawi. Dr. Ithar is an assistant professor in optometry, the head of the optometry department and optometry and low vision clinic at An-Najah National University, Palestine. Dr. Ithar has received numerous awards, published many scientific articles, and regularly presents at international conferences. She was instrumental in establishing the Low Vision Center at An-Najah to be the only center in North Palestine which provides low vision assessment and rehabilitation services. We are lucky to have her with us today. It is my pleasure to now invite Dr. Ithar to present her topic.
Hello, thank you so much for the great introduction. I'm so glad to be with you today. Hopefully, maybe in the future years, we'll gather, not virtually, we'll gather together for such webinars. And thank you for inviting me, and we'll start soon. I'll share my slides. Okay, so good afternoon, everyone, and welcome to the Insight on Low Vision Practice webinar. This talk will be the first of a series of webinars that will introduce you to the topic of low vision, discuss the prevalence and nature of visually impairing disease, explain the ocular disease lead to low vision, outline the effects on visual functions, and touch on the social and psychological effects it could have. And it will explain how to assess the requirements of visual impaired patients. And at the end, we'll describe some of the optical and non-optical aids used for people with vision impairment. So this talk will be divided into two parts. In the first part, we'll talk about introduction, some definition, and numbers of low vision, risk factors that could lead to low vision, and causes of visual impairment. Then we'll take a break for 5 minutes. Then we'll talk about the effects of low vision, the assessment, and how to prescribe for people with low vision. So as we all aware of, vision is the most dominant of our senses. It plays a critical role in every phase and stage of our lives. Sometimes we take vision for granted, but without vision, we struggle to learn, to walk, to read, to participate in school, and to work. From the moment of birth, vision is critical to the child development. For infants, visually recognizing and responding to parents, family members, and caregivers facilitates cognitive and social development and the growth of motor skills. coordination, and balance. From early childhood to adolescence, vision enables ready access to educational materials and it's pivotal to educational attainment. Vision supports the development of social skills to foster friendships, strengthen self esteem, and maintain well being. It is also important for participation in sports and in social activities that are essential to physical development, mental and physical health, personal identity, and socialization. Also, in adulthood, vision facilitates participation in workforce, contributing to economic benefits and a sense of identity. It also contributes toward the enjoyment of many other areas of life that are often designed around the ability to see, such as sports or cultural activities. Even later in life, vision helps with maintaining social contact and independence and facilitates the management of other health conditions. Vision also helps to sustain mental health and level of well being, both of which are higher among those with good vision. So, visual impairment occurs when an eye condition affects the visual system and one or more of its functions is affected as well. Vision impairment has serious consequences for the individual across the life course. Many of these consequences can, however, be mitigated by timely access to quality eye care and rehabilitation. The WHO defines low vision as visual acuity less than 6/18 to light perception, or a visual field less than 10 degrees in the better eye with best possible correction. Visual impairment comprises categories 1 to 5 depending on the visual acuity. So if the person has a visual acuity between 6/12 to 6/18, he or she has a mild vision impairment, and they would have a moderate vision impairment if the visual acuity is between 6/18 to 660, and severe vision impairment if the visual acuity is between 6/60 to 360, of course for distance vision. But for near vision, if the patient has an acuity of N6 or M size of zero point 0.8 at 40 centimeters, and the patient is considered blind if they have a visual acuity worse than 3/60. However, the problem with this definition is that there may be people with a visual impairment whose ability to perform everyday tasks is greatly reduced, but who do not fall within this definition. For example, if someone who wants to drive but their visual or distance visual acuity is worse or about 6/12, then the low vision services consensus group defined low vision according to the person's functional ability rather than any specific level of acuity or other clinical measurements of function. And it defines low vision as a person with low vision is one who has an impairment of visual function for whom full remediation is not possible by conventional spectacles, contact lenses, or medical intervention, and which causes restrictions in that person's everyday life. So, in this definition, it is not just a function of a disease, but the activities the person wants to do and how they participate in a given life situation. So this table here shows some examples of ocular conditions and their adverse effects on the patient's activities and participations. For example, if a patient has macular degeneration, they would lose the central visual field. This will lead to a difficulty in recognizing friends and the faces of their friends. So, and consequently, it might lead to breakdown of social relationships. Another example, if a patient has cataract, they will have increased glare sensitivity, which will affect the driving, especially at night. So the person with the cataract may not be able to go out and drive to visit their relatives. So let's talk about the number of people with low vision. Globally, there is at least 2.2 billion people have a vision impairment or blindness, of whom at least 1 billion people with moderate or severe distance vision impairment that could have been prevented or has yet to be addressed, including around 123 millions of people with uncorrected refractive error, 65 millions of people having cataract, 6.9 million of people having glaucoma, 4.2 million of people having corneal obesities, 3 millions of diabetic retinopathy, and 2 millions of people having trachoma, as well as near vision impairment caused by unaddressed presbyopia, around 826 millions. And if we look at the number of people with low vision by region, we see that considerable variation is observed in the distribution of presenting distance visual impairment between regions and income levels. So if we look at the Middle East region here, the one with the circle, with the red circle, we see that there is around 29 millions of people with vision impairment that could have been prevented. 10 millions of them, they have vision impairment that could have been prevented or addressed. And generally speaking, the prevalence in many low and middle income countries is estimated to be four times higher than people with or regions with high income countries. And if we look here at the global estimation of presbyopic patients, for sure, the prevalence of any near vision impairment is highest in regions with longer life expectancies, while the greatest burden of near vision impairment yet to be addressed, which occurs in low or middle income countries. In the Middle East region, the rates of unaddressed near vision impairment are estimated to be higher than high income countries or region, but much less than the other regions such as Latin America, South Asia, and East Asia. There is a number of factors that could affect the visual impairment, which leads to differences from one region to another, depending on similar factors such as the age and gender. So distribution of eye conditions varies across ages due to the typical age of onset. While some eye conditions such as myopia, retinopathy of prematurity, and amblyopia occur in childhood, the risk of others, including cataract, presbyopia, glaucoma, and age-related macular degeneration, increases with age. And according to gender, at a global level, there is no strong association exists between gender and many eye conditions, including glaucoma, age-related macular degeneration, and diabetic retinopathy. However, rates of cataract, uncorrected refractive error, and uveitis are higher among women, particularly in low and middle income countries, while higher rates of congenital anomalies, retinal detachments, trauma, and optic atrophy are found among men. Other factors that can influence visual impairment prevalence is the access to eye care, of having the best correction or treatment or operations, and the area of residency, as it's an important determinant of many eye conditions. For example, cataract is a leading cause of visual impairment in developing countries, but age-related macular degeneration is a leading cause in developed countries. So let's talk more about causes of low vision. So what are the causes of low vision? Actually, it is essential to identify the pathology which is causing low vision, not least because of the need to consider whether medical treatment is required. So you need to understand what the disease is, be familiar with signs and symptoms, understand how the disease affects function, and develop disease-specific visual rehabilitation management plan. So globally, the principal causes of visual impairment are uncorrected refractive error around 42%, and cataract around 33% of people, and other causes such as glaucoma 2%, age-related macular degeneration, diabetic retinopathy, trachoma, and corneal obesities all about 1%. A large proportion of causes are undetermined around 18%. So if we look at the distribution of eye conditions, it varies across ages due to the typical age of onset. The prevalence of visual impairment and blindness are determined by the WHO for three age groups. The first one is the babies and infants who ages from 0 to 14 years. The second group is the middle-aged people who age from 15 to 49 years. And the third group is the elderly who ages from 50 years and older. So the first group are the infants and babies. So there are a few signs that we see in visual impairment infants or children, such as the absence of fixation at birth, absence of visually stimulating reaching around 4 to 6 months, abnormal ocular movements, abnormal pupillary reactions, eye rubbing, lack of facial mobility or expressions, and absence of optokinetic nystagmus, which is important as a sign of integrity of visual system. So there are numerous of ocular disease that cause visual impairment among infants and babies, such as albinism, congenital cataract, congenital glaucoma, Leber's congenital amaurosis, optic atrophy or hypoplasia, or macular coloboma. Additionally, there are a few other reasons or ocular disease such as retinopathy of prematurity, retinoblastoma, primary hyperplastic vitreous, high refractive error, delayed visual development, and congenital idiopathic nystagmus. Among older children, other causes could lead to visual impairment, such as Best disease, cone dystrophy, optic atrophy, retinitis pigmentosa, Stargardt's disease, and X-linked retinoschisis. In the middle-aged people, the causes are different, such as diabetic retinopathy, pathological myopia, acute optic neuritis, posterior uveitis, and cytomegalovirus retinitis. Most of the ocular disease that leads to visual impairment are diseases which happens in the retina or the posterior part of the eye. The psychological issues are very important for newly diagnosed middle-aged people. So you need to be honest and give them practical advices, because visual impairment in this category may result in loss or a change of employment, driving privileges, and a change in interpersonal relationship. So you need also to give them advices regarding genetic counseling about transmission the disease to their children. Let's talk about the visual impairment causes in the elderly. So globally, the leading causes of moderate or severe vision impairment in those aged 50 years or older were uncorrected refractive error or cataract, and followed by, as we can see here, age-related macular degeneration. But in the Middle East also, we can see that similar causes or similar disease can lead to visual impairment, such as the uncorrected refractive error and cataract. The other common causes that could lead to visual impairment in the elderly are age-related macular degeneration, cataract, glaucoma, temporal arteritis, central retinal artery occlusion, and anterior ischemic neuropathy. Okay, so now we'll continue with the effects of low vision. So the reduction in visual function experienced by people with a visual impairment has ramification in all aspects of a person's life. Most people with low vision experience difficulties performing everyday tasks like cooking, taking medications, reading, watching TV, and getting about. For instance, a reduction in visual acuity causes difficulty seeing the fine details, including small print, signs, and TV subtitles. Conditions affecting the macula, such as macular degeneration, diabetic retinopathy, and conditions affecting ocular media, such as cataract, and the cornea, such as scarring or keratoconus, cause reduced visual acuity from the early stages in the disease progression. People with nystagmus would also have reduced visual acuity, and people with peripheral retinal conditions such as retinitis pigmentosa and diabetic retinopathy or optic neuropathies such as glaucoma may have good visual acuity initially, but progresses to have reduced visual acuity. A loss of central visual field causes difficulty recognizing faces and seeing print. The development of central scotomas affecting fixation, and people will have unsteady fixation and adopt eccentric viewing. Many people with central visual field loss will report difficulties with mobility and orientation tasks. Conditions affecting the central retina, such as macular degeneration and diabetic maculopathy, could lead to central visual field loss. Although binocular peripheral visual field loss is not as common as either a reduction in visual acuity or central visual field loss, as a cause of visual disability, it can be extremely disabling. When the visual field is reduced, the person will have difficulty getting enough information from their environment to orientate themselves and move safely within it without bumping into things or getting lost. Difficulties can also be experienced with near tasks, for example, in finding their way around the page of text. So most people learn to scan the surrounding and thus will have a larger dynamic visual field. If these patients also have reduced central vision, prescribing low vision aids can be particularly challenging to ensure an aid works ergonomically while not magnifying into an area of loss. Some conditions, such as diabetic retinopathy, could lead to patchy vision, which leads to difficulties in near work and fluctuating of vision. The loss of contrast sensitivity affects all aspects of person's life. The world is not made up of high contrast objects, and so a reduction in contrast sensitivity means all sorts of tasks becoming difficult. The ability to see a car, find a door in a room, be aware of where a chair is, finding the food on a plate, or distinguishing money may be reduced if a person's contrast sensitivity is reduced. So reduced contrast sensitivity has been found to be actually one of the most significant factors in older people falling. Therefore, it is not surprising that object contrast has been found to be a significant factor in determining the success of visually impaired person in avoiding objects in a travel path. Cataract causes a marked loss of contrast sensitivity at all spatial frequencies. In macular degeneration, only when the scotoma is small, a reduction in contrast sensitivity may only occur at high spatial frequencies. But as the disease progresses, moderate loss of low spatial frequencies can occur. Glaucoma and retinitis pigmentosa could lead to a moderate loss of contrast sensitivity. Glare also is a significant subjective problem associated with many eye disease. There are several types of glare, such as disability glare, discomfort glare, and photophobia. Conditions affecting the cornea and the lens, for example, keratoconus, cataract, aphakia, and lens subluxation, usually cause a person to experience both disability glare and discomfort glare. Photophobia usually affects people with anterior segment conditions such as achromatopsia, albinism, anterior uveitis, corneal ulcer, and aniridia. You know that normally when we move from a dimly lit room to outdoors on a bright day, it takes a few seconds for our eyes to adapt. Some people with low vision have a much slower adaptation to increases in ambient illumination, and it can take several minutes for their vision to be optimized. Macular degeneration and conditions affecting foveal function and conditions such as retinitis pigmentosa, which have a marked effect on rod functions, causes light adaptation to be very slow. People with conditions affecting the media, cornea, and optic nerve functions are generally unaffected. On the other hand, when we walk into a dark room, your vision will adapt after a short time so that you are able to see well enough to navigate safely. But some people with low vision have much longer adaptation times, and a few never adapt, so that they have great difficulty navigating at night. Any conditions that affect rod function will affect dark adaptation and night vision. The best known being is retinitis pigmentosa. Conditions affecting the peripheral visual field will also cause a reduction in dark adaptation if a large extent of peripheral field is lost, for example, in the stage glaucoma. Additionally, dense cataract may reduce the little amount of light reaching the retina at night and therefore reduce person's ability to function in the dark. A reduction in color vision can cause difficulty in performing tasks that require processing of color information, such as coordinating clothing colors. People with conditions that affect the fovea, such as macular degeneration, Stargardt's disease, generally have poor color vision because of the loss of foveal cones. Many acquired conditions affect blue sensitivity, such as glaucoma, cataract, and optic neuritis, although the patient is often unaware. People with a visual impairment are less likely to go out alone and have difficulties in using public transport. And most people with low vision are older and are more likely to live alone and have other ag-related conditions such as hearing loss and physical limitations. They are therefore frequently isolated and confined to their home for long periods. So let's talk about low vision assessment. So in order to help the people with low vision, we need first to understand their visual abilities in order to provide them with the appropriate aids, training, and advices to use their residual vision to its maximum potential. But at first, we need to explain to the patient that this assessment is not magic nor a cure. And as a professionals, we need to communicate better with the patient, understand their needs, gain their trust, and manage their expectations. Before starting the vision assessment, we should be clear about what we are going to do, what is possible, and what is not in order to gain their trust. Always during the assessment, provide clear instructions and explain what you are going to do. Always be patient and give time to the visual impaired patient to answer. Write down the answers and the behaviors. Also assure emotional support and encouragement. And with the children, you need to find other strategies to keep their attention. And please do not let the person know when they make mistakes. And do not stress the person saying hurry up or look harder or try better. And do not let the assessment to last more than 1 hour. The low vision assessment is a problem-solving exercise to which there is no one correct solution. It can be broken down into 3 main steps. The first step is the case history, where you find out what the person needs and wants to do and set goals accordingly. Then you assess the person's current visual functioning. Once you know what the person wants to do and what they can see, you try to find the most suitable way the person can achieve their goals or modify the person's expectations accordingly. So the case history in a low vision assessment is usually longer and more in-depth than a normal eye examination. The success of a low vision assessment is often down to this important first discussion. You will need to encourage the person to open up and share their experiences and feelings, assess their motivation, and find out how well they are functioning in all aspects of their lives. So from the moment you meet the person, you can get a lot of information by assessing if they look straight at you or use eccentric fixation, if they are sensitive to light, do they wear tint, a peaked hat or shielding their eyes, and if they need you to guide them or can they orientate themselves independently. During the visual history, you need to get information about the diagnosis, if it is known, the onset of the impairment, the duration and the circumstances, the stability of vision, a description of what they can see or they don't see, if there is a differences between the two eyes and if one of them is better than the other, knowledge of the conditions and its prognosis, if they know, information about the current, past, or future treatments they have, and the current spectacles or present, or if they have any low vision aids. Also, you need to get details of the systemic conditions which may lead to a visual impairment, such as diabetes or multiple sclerosis. They need to be determined, as well as the usual information about general health and medications. Because most people with visual impairment take some form of medication, and not taking the correct dose can have serious consequences. Also, you need to know about their social situation, if they live alone or they have a family. Most people with low vision will report difficulties in reading. So it's important to find out what the person can read and what they need and what they want to be able to read. Also, you need to know if the person is in work or at school. So if they are in work, what does their job consist of? What causes them the most problems? And you need to know if they have any equipments or training. And if the person is at school, you need to know what causes them most problems, and how do they access information from the board or the textbooks, and how do they manage with the sports or homeworks. Also, you need to ask your patient about their mobility, because not being able to get out and about could lead to isolation. Also, you ask them about communication, how they communicate with others, because communications is another important aspect of preventing isolation and loss of independence in visual impaired patients. Cooking is also a major point, because for those who live alone, the ability to keep cooking for themselves may be one of their most important goals. So determine the person's ability to see dials on the cooker and microwave, read recipes, buy food, read instructions on packets, shop foods, or pour liquids. Also, you ask them about their hobbies. So finding out what the person likes to do once the essential chores are taken care of, determine any problems they have and solution they may have tried themselves previously. So when the case history draws to a closure, you should have a good picture of the person in front of you, their character, their life, how their eye condition has affected them, and what they most need and want to be able to do that they cannot do anymore. Lots of areas of difficulties will have been highlighted, but you need to prioritize. So you need to decide on 2 or 3 goals, which you as an optometrist or eye care professional are going to try to address in that session. So step 2 is about assessment of the visual function. The first point is to assessing the distance vision and visual acuity, which should be recorded monocularly and binocularly. And usually we start by binocular vision acuity, then monocular visual acuity to give the patient confidence. Lookmark distance visual acuity charts are much better and are much more useful within the low vision context. Always give the person time and encourage them to use eccentric fixation. It is allowed for the visual impaired patient. And the chart should be held close enough so the patient can read a line or two of letter, but not all lines on the chart. So the visual acuity can be taken at any distance. It does not need to be at 6 meters, 3 meters, or 1 meter. It can be done at any distance, then we can calculate the visual acuity using this formula. So the visual acuity in decimals is equal to the distance or the test distance in meter over the letter size, the smallest letter size that the patient could read. Then we need to take near visual acuity. The traditional near charts usually do not have text large enough for a large proportion of the low vision population, so it's better to use the special low vision charts. Reading acuity is also important because it's a measure of the quality of vision. While visual acuity with symbols, reading acuity using texts of different sizes, and it is a key tool to determine the need for magnification for reading tasks. The second or the third point is to assess refraction. High and shifting refractive errors are very common in low vision population. So this table here shows us the expected refraction shift according to different eye disease. For example, if a patient have cataract, we expect them to have myopia. If the patient have Down syndrome, they could have moderate to high myopia. And if a patient have nystagmus, for example, they could have moderate astigmatism. So it's important, we could use retinoscopy as an important tool to assess refraction in low vision, although it might be challenging sometimes because of the cloudiness in the media for some ocular disease. And during subjective refraction, always be patient and take your time when refracting the patient with low vision. The phoropter is not recommended at all to be used with low vision patients because it does not allow the person to use their habitual head posture or eye position like eccentric viewing. And it is not easy to use a large incremental changes required in a low vision assessment because we do not change in a quarter step. Sometimes we need to change in 1 diopter step or 3 diopters step. So the phoropter is not easy to do that. The autorefractors also are not accurate because of difficulties with fixation, small pupils, and media opacities. The visual field in low vision assessment are required to give you an understanding of the field of view of a person and how this might affect their functioning because many ocular diseases could influence or affect the visual field. So we look for severe constrictions that may affect orientation and mobility, and scotomas that may interfere with near tasks or the use of low vision aids. And when the patient reports problems getting about, regardless of visual field defect, referral for mobility training should be considered. AMSLA regret testing can give useful information about the size and location of central scotoma or distortion, which could happen with many visual impaired patients. We need also to assess contrast sensitivity because it gives better assessment of the patient's functional ability in the real world. A person with good visual acuity but reduced contrast sensitivity may report difficulty recognizing faces or seeing the food on their plate. So it is useful when considering whether low vision aids would be of use and if there is a need to enhance contrast. Color vision is also affected in a large number of people with low vision, especially the ones who have retinal disease. It is most commonly assessed in children and people of working age for whom teaching and work practice may need to be adapted. At the end of the assessment, the functional implication of the key results should be explained to the person with low vision. This step can be taken as an opportunity to check the outcomes of the assessment correspond with the visual behavior of the patient. In all cases, we need to be careful not to make conclusions based on one single assessment. Solutions to be recommended to a person with low vision can be on forms of spectacles, optical aids, non-optical aids, or advices. Some people with a visual impairment are more likely to have high and changing refractive errors, as we discussed earlier. However, practitioners need to be more cautious than usual when prescribing spectacles as part of a low vision assessment because many conditions that cause low vision are progressive. So, spectacles prescribed may be no use to the person in just a month or two. Also, the major concern expressed by people with low vision when asked about going to optometry practices for low vision services was that they would be sold spectacles that they didn't need or they wouldn't get use of. So therefore, you need to be convinced that a change in the prescription will make a significant difference to the person. An improvement of at least 2 complete lines of visual acuity should therefore be achieved with the new prescription if you want to prescribe it and give it to your patient. Once you know what the person wants to see, have assessed some measures of their visual function, and prescribed the best spectacles prescription, you can start to try to help them achieve their goals. The first step is usually to find out what can be achieved with low vision aids. Once you have starting the magnification in your head, and in our future webinars, we'll talk about how to calculate magnifications. You need then to consider the nature of the task of person wants to do and the person doing it, and decide the suitable low vision aid, taking into consideration the different features of the aid, such as portability, lighting, use of hands, the availability of electric source when they go, and the duration of use. In addition to the weight and size of the device, ability to change batteries, and ability to hold the device and the task at the same time. So it's important to point to consider contrast also, because some patients' reading ability will not improve as you increase the magnification. Of course, for near low vision aids, they come in different types. There are the hand magnifiers. We have also the stand magnifiers, which could be illuminated or non-illuminated. And there are the spectacles, which could be monocular or binocular magnifying spectacles. There are also the distance low vision aids, such as telescopes, which could be binocular or handheld monocular telescopes. The principle for prescribing distance low vision devices is the same as near. Once you have starting calculating the magnification in your head, you should consider the nature of the task the person wants to do and they are doing. So if the person is sitting down for the task, then a spectacle mounted device should be considered. For outdoor tasks such as seeing street names, a handheld telescope or binocular telescope may be used in this case. Also, we have the electronic aids, which enhance the luminance contrast of the object being viewed and offer the option of reversing contrast, white on black, black on white, yellow on blue, or blue on yellow. If the person has very reduced contrast sensitivity, the CCTVs as an example of electronic aids can enhance the contrast and magnify as well to help them to achieve their goals. Some types of the CCTV has also cameras for near and distance. So for example, a student in school or university can use the CCTV to read the book and also to see what the teacher is writing on the blackboard. There are also non-optical aids, because optical low vision aids or magnifiers will not be the only answer for everyone and for all programs the person could express. For some goals, advices about lighting or contrast will be important. Many low vision patients suffer from discomfort glare, so changing their use of lighting may also make them feel more comfortable. Many people are not aware of their current lighting arrangement and the benefit that they can get if they improve the lighting. Discomfort glare can be removed also by reducing the light with a tint or wearing a hat with a berm or sport hat. Also, there is the typoscope, which is a rectangular black card with a central slit. It reduces the amount of light from the background and so reduces the scatter and thus increasing the retinal image contrast. And it can also assist in reading along lines, finding the next line, or guide signing and writing. Also, using felt pens is a good suggestion for people with visually impairment. There are also few ideas to adapt around the house or for mobility and walking outside, such as using the liquid indicator, which will make sounds when the liquid touches the sensors. There is also the easy to see timer, which has good contrast, black to white, and magnified numbers. The plate surrounds during eating. There's also the eye drop dispenser if they need to use an eye drop medication. There is also the talking microwave, which could also send sounds about the quantity of minutes or seconds the person wants to use. Also, the long cane could be helpful if the patient wants to go outside for a walk alone. So following up with a low vision patient is very important. This will allow you to establish how the person managed with their low vision aid and work on any problems they encounter during this time. Ensure that the aids and spectacles are dispensed the most appropriate way. Go over basic training in the use of the aids, clarify points not understood or forgotten from the assessment, address a problem you didn't have time to address in the first appointment. For example, telescopes are often prescribed at the second appointment once the person's ability to use simple low vision aids can be assessed. So this draws us to the conclusion. This is my last slide. So as we learned from this webinar, vision impairment has a serious consequences for the individual across the life course. Globally, there is at least 2.2 billion people having visual impairment, of whom at least 1 billion have a vision impairment that could have been prevented or has yet to be addressed. Population aging coupled with lifestyle changes is leading to dramatic increase in the number of people with eye conditions and vision impairment. There is a range of effective strategies to address the need associated with eye conditions and vision impairment across the life course, which includes health promotion, prevention, treatment, and rehabilitation strategies, some of which are among the most feasible and cost-effective of all healthcare interventions to be implemented. Eye care is very good investment, so preventing eye conditions and vision impairment will lead to improved productivity and reduce informal intangible costs. So we need to collect and report information on the met and unmet eye care needs of the national population in each country, integrate eye care into national health strategic plans, and raise awareness about the availability of effective intervention that address all eye care needs across the life course. You will be surprised that some people, especially women and children, are not aware of the low vision aids or rehabilitation ways that could be used to make them use the residual vision to their full potential. So thank you so much for your attention, and hope that you get benefit from this webinar.
That was a really detailed webinar that you conducted for us. Thank you so much. Very happy to hear from you. I have received a few questions. Okay, the first question is, what is the best and recommended methodology to achieve the magnification of magnifiers for near vision aids? I will repeat.
Okay, yes, please. Okay, so actually, it's important to get the reading acuity, to see what the patient can read and to see what they want to read. And then we can calculate the magnification. The magnification can be given in different ways, either by enlarging the script size, or getting closer to the reading material, or by giving them magnifiers. And the magnifiers, as we saw, they are on different types. There are handheld, there are spectacles, not these spectacles, special ones, and other types. And we can combine, actually, we can combine between like enlarging the material size and giving them magnifiers.
Thank you so much. The next question is, it is a little long. I will read it out to you.
Mm-hmm.
The leading cause of low vision is refractive error.
Okay.
Do you mean corrected or uncorrected refractive error? And which type of refractive error is the biggest cause of low vision? Is it myopia, hyperopia, or astigmatism?
Okay, so it's uncorrected refractive error which leads to low vision. And actually, high refractive error is the one which causes low vision. And I think that myopia, because there is high prevalence of myopia, is the leading cause or the most prevalent refractive error.
Okay, thank you. And the next question is, the assessment period should not last more than 1 hour. So what is the average enough period for assessing vision of low vision patients?
Actually, you know, because the visual assessment is a bit hard with visually impaired patients, so it takes long time. Sometimes we need 2 or 3 sessions, and it depends on the patient himself, if they will get bored or if they are cooperative or not. So usually don't make it last more than 1 hour. You can call the patient for 1 or 2 sessions for no more than 1 hour.
Okay, thank you. One of the questions here is this lecture more for theoretical work or also for practical purposes?
Say it again, please.
Is this lecture helpful for practical purposes or only for theoretical work?
Okay, actually, so before you start the practical work, you need to understand a few things like the that we mentioned in this webinar, like the ocular disease and its effects on vision. So when you get a patient with macular degeneration, you expect what they have. Do they have loss of peripheral visual field or loss of central field? Would they have refractive error like myopia or not? So you need actually to understand the eye disease, the signs and symptoms, so you know the nature of this disease and its effect on the visual system of this patient, so you know what to do with them and how to help them. Okay. Because in some cases, actually magnification is not helpful. Like if the patient has retinitis pigmentosa and he has tunnel vision, so if you magnify the material they need to read, on the contrary, you're making the problem even worse, because they will need to scan to see a word, a full scan just to see one word. So that's why at first you need to know some theoretical points before we go to the practical side.
Thank you so much, Dr. Itar, for answering all those questions. We are receiving very good feedback on our chat box. We will send that to you. Everyone has enjoyed your webinar, and thank you. One of our participants has asked whether it's a certified training. May I answer this question for him? Eyezone will soon announce accredited training programs. So please stay tuned on our social media. And we will announce it soon. We will announce a training program soon. I believe these were all the questions that were asked. If there are any more questions, our audience can send us an email about them and we will forward it to Dr. Itar. I believe we've come towards the end of our session. Before we end it, of course, my heartfelt gratitude and sincere thanks to Dr. Itar on behalf of Eyezone Education for the insightful webinar. I'm certain it has added value to our participants today. Thank you for your patience with us, for the coordination and everything. It was really nice. May I also thank our attendees for their cooperation and being a wonderful audience. We have more events coming up on low vision. Please visit our social media handles for all updates. On behalf of our Eyezone team, I thank all our supporters and well-wishers. Thank you once again. If we don't mind, I think there is one question that has come in. Dr. Itar, would you like to answer one more question?
Yeah, sure. That's fine. Sure.
We have a question which says, from your experience, what management you can give for peripheral field loss?
Okay. So actually, again, you cannot decide or give one magnification or one tool for every patient. So it depends what they want to do in their life. If they would like to read, to study, to go out, to cook. It depends on the patient's lifestyle, actually. There is no one solution for all patients in the same, who have the same disease.
Okay, I hope that answers the questions of our audience. Thank you so much.
Actually, I'm also thinking of maybe for next webinars, maybe we'll get some, discuss some cases. So we have a full case in a patient with full history, and we can discuss what are the optical or non-optical aids that can be benefit to this patient, but they might not be beneficial to another person with the same disease. So we can understand and know the differences.
Correct.
Yeah.
Thank you so much. That I'm sure will be helpful.
Sure.
And definitely we will plan more such webinars based on the questions that we have also received today. With that, I would like us to close this webinar now. Thank you once again to Dr. Itar, and thank you to all our audiences and to Eyezone supporters.